Next up, we've got Kenneth Rubango, and Kenneth is very kindly talking today about his presentation, which is Towards Sustainable Medical Device Health Systems, Strengthening in Low Resource Settings, with a case study of wheelchairs and artificial limbs in Uganda. Thank you, Kenneth.
Yes, thank you, Dr. Head. Hello, everyone. I hope you're all doing well. I'm talking about my PhD project that is pursuing work towards health system strengthening, sustainable health system strengthening for low resource settings in terms of medical devices, with a case study of wheelchairs and artificial limbs. And the title of this presentation is focusing on a partnership between researchers, an established NGO, an overseas manufacturer, and to address chronic problems with prosthetic supply in Uganda. I am a part-time PhD student with the University of Salford, working with the Fit for Purpose lab that is headed by Professor Kenny Lawrence. If we could move on to the next slide. This presentation is geared to have us take away the learning objectives, which are to identify the biggest impediments to access of prosthetic and orthotic products in low resource settings like Uganda, to recognize the aspects of sustainable prosthetic and orthotic supply chain suitable for low resource settings, and to allow us to rethink the role of non-profits in the prosthetic and orthotic supply value chain in low resource settings to ensure sustainability. In effect, this is a progress for the PhD research that is trying to address the main topic that that my presentation is about. Can move on to the next slide. On Ugwang's story. So I came up with a schematic here to allow us to hopefully clearly understand the problem in the story of Ugwang, who at one point was traveling to school, and unfortunately in northern Uganda, due to civil war that had ensued there, a landmine hit his leg and he lost part of his leg, was rushed to hospital, and while in hospital, it was actually Gulu Regional Referral Hospital that is located in northern Uganda, where a prosthetic limb was procured from Switzerland to help Ugwang be able to walk again. So Ugwang, thankfully, was able to continue going to school, thanks to the Red Cross, International Red Cross, that was at the time in the region trying to support war victims from the Kony War. But 3 years later, inevitably, Ugwang's leg needed spare parts, and because the war in the northern Uganda had ceased, and the mandate for the Red Cross was done in that area, the Red Cross had left and gone to other countries with more need. But Ugwang still needed spare parts, and because of that, Ugwang couldn't find the spare parts, and he had to use the limb the way it was. But then 5 years later, as is the case for most prosthetics, it needed replacement. In this case, he went back to where he got it from, which was the regional orthopedic workshop. And unfortunately, he couldn't once again access he couldn't access a replacement limb because there was no local distribution of these prosthetic limbs. The regional workshop did not have any other supplier and no other donor to give them the limbs. So Ugwang, in this case, had to find a way to access this limb, and the only way was to import that limb for himself. Now, to import the same limb that he had been donated to a couple of years ago, 5 years ago, Ugwang had to part with $10,000 US to be able to access a limb that would replace the one that was donated. And he had to pass through the same regional orthopedic workshop. But then, having been told that Ogwang had no choice but to go back home without a limb, as he was before the Red Cross intervened, because Ogwang is from a normal family, an average family in Uganda, that has $110 US per month. Now, if you try and do the math, you see that $10,000, which was the cost of the limb, is definitely not affordable to Ogwang's family, and Ogwang is an average Ugandan, so we can as well say that the average Ugandan will not be able to pay for this limb that is $10,000, and we are going to find out some of the reasons why these limbs are prohibitively cost unfriendly. If we move on to the next slide with statistics to show us a little bit of how many people like Ogwang are facing this plight. We know that according to the ISPO, about 0.5% of the population in low and middle income countries are in need of prosthetics and orthotic products, but 77% of them have an unmet need. And this was data from the World Disability Report. To put that into perspective, we have globally 32 million that are in need of prosthetics and orthotic products, and about 25 million of those do not have their need met. If we come closer to home in Uganda, we see that we have about 205,000 individuals that are in need of prosthetic and orthotic products, but of these, about 158,000 of them have an unmet need. And that begs the question, why is it that we have these gross percentages not being able to access these prosthetic and orthotic products? If we move on to the next slide, it really hints to the problem statement, which is what was introduced in Ogwang's story, and the problem is really cost to access of prosthetic devices in low and middle income countries. And this is backed by a recent research in Tanzania by Ibrahim et al. It is as recent as 2019. And delving a little bit deep into that, we see that a prosthetic device could cost between $15 up to $50,000 US. And if we look at the average household income, the $110 was average household income, not individual income, of $110 per month. You see that it should explain why a big percentage of the Ugandans in need of prosthetic and orthotic devices do not have access to them. The biggest impediment is cost, and has been backed by research. So if we move on to the next slide of methods and results. So we tried to intervene by first having identified the problem from published literature, and this was the stage that I was trying to build my literature review, trying to understand the problem and how big it is, basically trying to scope out where the potential intervention for the PhD would be, and where it would be most impactful. We then moved on to conduct a needs assessment, and this was really preliminary work that involved user engagement. I had a trip to Gulu Regional Referral Hospital, and I met some of the orthopedic technicians at their workplace. I had a chat with them, and I learned that there are a couple of non-profits that come in and they do direct procurement of the orthopedic products, and when their mission is done, unfortunately, the local capacity is not built to be able to manage the supply chains independently of the donors. So this was cited as a problem. But I also interacted with prosthetic researchers, and these are the researchers at Makerere University and University of Salford, to try and understand and guide the next steps, where the problem could be and where potential intervention could be. And this is where I'd like to really send a shout out to Professor Catherine Holloway. The product narratives that were published on both wheelchairs and prosthetic devices helped a lot to understand that there are other products that are in the healthcare supply chain that have faced similar problems, and they have been solved in different countries using different methods. We'll just take a little dive into that in the next slide or so. But then I was also fortunate because I work with Joint Medical Store, who is a distributor of medical devices in Uganda, one of the oldest distributors here, been in business for over 40 years. So we looked at trying to have an intervention to this problem that we had found. So I traveled to China and met with Nobel Prosthetics Limited, who we partnered with to start introducing these prosthetic devices locally in Uganda. So having interacted with them, we got to learn a couple of challenges that the manufacturers also face when they're trying to introduce these devices in countries like Uganda, particularly in after-sales services. It's there that we learned that prosthetics are different in most devices. The level of repair that you can do is minimal because alignment of the limb remains very crucial. So the manufacturer gives you warranty that covers specific aspects of the device. So it was good to get to know that even Red Cross was procuring from manufacturers that in different countries, like China. So we learned lessons, but the two most pronounced ones were that in the regional orthopedic workshops, the biggest problem is stockouts. And the stockouts are not really for very complex equipment, but it also goes down to the plastic sheets that are used to fabricate the sockets. It's very often that these run out of stock, and this should not be a problem for the local supply chains if the capacity is built. So this was one of the overarching problems that was noticed in these user engagements and needs assessment. And the other one was the fact that there was lack of clarity on which prosthetic items were tax exempt. In Uganda, all medical devices are tax exempt. However, some of the consumables that are used in orthopedic workshops are also usable in the construction industry. So when you're importing these, you have a problem to justify that you're bringing them in for use in an orthopedic workshop if you're not a designated importer of medical products and sundries. So this was a challenge that these orthopedic workshops were facing because they were importing directly, but they were not using procurement personnel. They did not know how to maneuver the tax landscape in Uganda. So all this contributed to the high cost of the prosthetics. And if you realize that the orthopedic workshops themselves were importing the prosthetics on demand, they were most definitely bringing in small quantities, and the patients were now not benefiting from economies of scale. So rather than bringing 20,000 prosthetic limbs, one would bring in one, and the cost of shipping for that one would be not friendly to the eventual price of the prosthetic, especially to someone who lives in an average household like Ogwang in Uganda. So those are some of the contributors to the prohibitive cost of these prosthetic devices. We move on to the next slide. We will look at the interventions that we have found to be probable solutions because they have worked elsewhere. And this has been informed by market shaping articles by the GDI Hub. We see market shaping interventions that involve system-wide thinking, inter-system linkages, change management, and proper governance as potential solutions. Gavi had a problem with the high cost of vaccines, but because of direct negotiation with manufacturers for combined markets, Gavi decided to approach manufacturers of vaccines and present to them a market as big as, let's say, Africa, and negotiate big volumes. And this intervention, though seemingly simple, actually was able to have the cost of the vaccines that are now being used in the low and middle income countries. So such an intervention should not be restricted to vaccines only. We believe that it can be replicated for prosthetics as well, to be able to lower the cost, because we now know that the biggest impediment to access of these devices is cost. The next one is the fact that we see a very big gap in data in the country about the actual needs of prosthetics and orthotic devices and products. So we believe that a nationwide data collection platform using a custom inventory management system will help, especially if it's in a partnership with researchers, policymakers, and the users themselves. The policymakers do not have data, and this moves right on to the next point. There is not enough data to inform their policy design. If you work in the Ministry of Health in Uganda, you may not appreciate why you should prioritize national funding for prosthetics if you do not have the data of how many people are out there that are without limbs, and how much they would contribute to the national economy if they had limbs. So it is data like this and the involvement of researchers to inform the policymakers that is important, and it's really one of those interventions that could make a difference. If we move on to the next slide, we see that these interventions could actually not be restricted to a country like Uganda. Uganda is just one of the many low-resource countries. We have 134, and we believe that this impact could be scalable to the other 134 middle-income countries. And we believe that this is a phenomena that could also be extendable to other medical devices. We know that 80% of the medical devices in low and middle income countries are donated, and in one way or another, they all face the problem of lack of capacity building. When you donate something, it's good, but it may not build local capacity to know why we need that equipment, why we should actually plan part of our revenue to equip the health facilities, and why we need to plan for other aspects of that medical equipment as well. With this slide, I'd like to also add that the PhD is evolving it's evolving, but it's really focusing on supply chain failures that are affecting medical devices, mainly looking at artificial limbs, and now we have moved on to also ask more interesting questions about supply chain failures potentially impeding research based on procurement problems. I understand that many of us here in the research area, and we have many times found it hard to procure maybe reagents or medical equipment, particularly labs, when you're doing work in low and middle income countries for one reason or another. So the PhD is evolving to look at that as well. It's something under consideration, but really this is what we've done so far, and we thank our collaborators and our advisors. Thank you so much. Can move on to the next slide. I'm happy, in case we are out of time, to answer questions offline. Thank you.
Hi, Kenneth. Thank you very much for that. We're just going to move on to John now for a very quick question, because we're running out of time.
Yeah, we're very conscious of time. Kenneth, I really enjoyed that. Thank you very much again. Just very quickly, do you know roughly the proportion of sockets that are made and sockets that are donated in terms of supply?
That is some of the data that we'll have to find out, but in my preliminary interaction with orthopedic technicians, we've not interacted much with sockets that are donated. Right. We mostly fabricate the sockets here.
Yeah, I would imagine. Yeah, I mean, I would imagine that is best practice. I think sometimes there's a misconception about sockets being able to just literally pass from one person to the next. But I hope now we're seeing the evidence being gathered where it's not just the prosthetics community that appreciates the importance of the socket. It's also other industries, other people and governors, etc., are starting to realise that too. But look, thank you again, Kenneth. That was again a really interesting study, and good luck, I'm sure, with the rest of your PhD. Thank you.